Hi everyone, I'm Faizani El Matangal and I will be discussing the electrolyte potassium. The functions of potassium in the body includes regulation of neuromuscular excitability, contraction of the heart, ICF volume, and hydrogen concentration. Today we will know the potassium regulation, clinical applications, collection of samples, and determination of potassium. Did you know that the potassium concentration has a major effect on the contraction of skeletal and cardiac muscles? This is the regulation of potassium, and potassium is correlated with the renal function, tubular reabsorption, and secretion. As the cellular potassium gradually returns to the plasma, it is removed by urinary excretion. Note that chronic loss of cellular potassium may result in cellular depletion before there is an appreciable change in the plasma potassium concentration because excess potassium is normally excreted in the urine. There are three factors that influence the distribution of potassium between cells and ESF. 1. When potassium loss frequently occurs whenever the sodium-potassium negative ATPase pump is inhibited by conditions such as hypoxia, hypomagnesemia, or digoxin's overdose. Second one is insulin promotes acute entry of potassium into skeletal muscle and liver by increasing sodium-potassium negative ATPase activity. And the last one is catecholamines such as epinephrine or B2 stimulator promote cellular entry of potassium, whereas propanolol or beta blocker impairs cellular entry of potassium. Potassium regulation includes exercise, hyperosmolality, and cellular breakdown. In exercise, it increases plasma potassium by 0.3 to 1.2 with mild to moderate exercise. Forearm exercise during venipuncture can cause erroneously high plasma potassium concentrations. When it comes to hyperosmolality, uncontrolled diabetes mellitus causes water to diffuse from the cells, carrying potassium with the water, which leads to gradual depletion of potassium if kidney function is normal. In cellular breakdown, if the potassium releases into the ESF, like for examples are severe trauma, tumor lysis syndrome, and massive blood transfusions. This is the clinical applications of potassium, the hypokalemia and hyperkalemia. So what is hypokalemia? Hypokalemia is a plasma potassium concentration below the lower limit of the reference range. Potassium is the major intracellular cation in the body. And potassium concentration also affects the hydrogen concentration in the blood. An elevated plasma potassium decreases the resting membrane potential or the RMP of the cell. The RMP is closer to zero, which decreases the net difference between the cell's resting potential and threshold action potential. A lower than normal difference increases cell excitability, leading to muscle weakness. Hypokalemia can occur with gastrointestinal, urinary loss of potassium, and with increased cellular uptake of potassium. These are the causes of hypokalemia: gastrointestinal loss, vomiting, diarrhea, gastric suction, intestinal tumor, malabsorption, cancer therapy, chemotherapy, radiation therapy, and the large doses of laxatives. Renal loss, diuretics, thiazides, mineral corticoids, nephritis, renal tubular acidosis, hyperaldosteronism, Cushing syndromes, hypomagnesemia, and acute leukemia. Cellular shift, alkalosis, insulin overdose, and decreased intake of potassium. These are the symptoms of hypokalemia: weakness, fatigue, constipation. Often become apparent as plasma potassium decreases below 3. Hypokalemia can lead to muscle weakness or paralysis, which can interfere with breathing. Treatment of hypokalemia. In some cases, chronic mild hypokalemia may be corrected simply by including food in the diet with high potassium content, such as dried fruits, nuts, bran cereals, bananas, and orange juice. Symptoms of hyperkalemia: tingling numbness, mental confusion by altering neuromuscular conduction. Muscle weakness does not usually develop until plasma potassium reaches 8 millimoles per liter. Hyperkalemia disturbs cardiac conduction, which can lead to cardiac arrhythmias and possible cardiac arrest. Plasma potassium concentrations of 6 to 7 millimole per liter may alter the electrocardiogram or ECG, and concentrations more than 10 millimole per liter may cause fatal cardiac arrest. These are the causes of hyperkalemia: decreased renal excretion, acute or chronic renal failure, and its glomerular filtration rate is less than 20 milliliter per minute, hypoaldosteronism, Addison's disease, diuretics, cellular shifts, acidosis, muscle cellular injury, chemotherapy, leukemia, hemolysis, increased intake, oral or intravenous potassium replacement therapy, the artifactual, sample hemolysis, thrombocytosis, and prolonged tourniquet use or excessive fist clenching. So these are the causes of hyperkalemia. Next is treatment of hyperkalemia. Treatment should be immediately initiated when serum potassium is 6.0 to 6.5 millimole per liter or greater, or if there are ECG changes. To offset the effect of potassium, which lowers the resting potential of myocardial cells, calcium may be given to reduce the threshold potentials of myocardial cells. Therefore, calcium provides immediate but short-lived protection to the myocardium against the effects of hyperkalemia. Substances that acutely shift potassium back into cells, such as sodium bicarbonate, glucose, or insulin, may also be administered. Potassium may be quickly removed from the body by use of diuretics or loop. If renal function is adequate, or sodium polystyrene, sulfonate, or kiesalate enemas, which bind to potassium secreted in the colon. Hemodialysis can be used if other measures fail. Determination of potassium. The specimen are serum, plasma, and urine. To determine the method of potassium, it is ISE. For ISE measurements, a valinomycin membrane is used to selectively bind potassium, causing an impedance change that can be correlated to potassium concentration, where potassium chloride is the inner electrolyte solution. This is the reference ranges of potassium. For serum, it is 3.5 to 5.1 millimole per liter, and for plasma, in males 3.5 to 4.5 millimole per liter, while in females plasma is 3.4 to 4.4 millimole per liter. When the specimen is urine 24 hours, its reference range for potassium is 25 to 125 millimole per deciliter. First, the coagulation process releases potassium from platelets so that serum potassium may be 0.1 to 0.7 millimole per liter higher than plasma potassium concentrations. Second one, if the patient's platelet count is elevated or thrombocytosis, serum potassium may be further elevated. If a tourniquet is left on the arm too long during blood collection, or if patients excessively clench their fist venipuncture, cells may release potassium into the plasma. The first situation may be avoided by using a heparinized tube to prevent clotting of the specimen, and the second by using proper care in the drawing of blood, because storing blood on ice promotes the releases of potassium from cells. Whole blood samples for potassium determination should be stored at room temperature, never iced, and analyzed promptly or centrifuged to remove the cells. Fourth, if hemolysis occurs after the blood is drawn, may be falsely elevated, the most common cause of artifactual hyperkalemia. And that's all. Thank you.